Hi, folks. I'm Adam Mariano, President and GM of Healthcare Division for LexisNexis Risk Solutions, and this is our podcast, Healthcare Data Wakes. We all know that the American healthcare system often struggles to serve everyone equally. It's often difficult for folks to navigate the fragmented and ever-changing operating system, if you will, that powers healthcare. And we like to think of people like ships on water. We all generate a little bit of a bow wave and a stern wake of data as we trail through the system. And this podcast is really about how people are finding better ways to leverage this data and to better serve patients and their families. So I'm happy to welcome today Joel White. He's the president of Horizon Government Affairs, a full service government affairs firm based in DC that has deep expertise in our complex medical ecosystem. Hi, Joel. Thanks for joining us today. I was hoping you could start with a little bit about your journey and some background on Horizon's mission.
Yeah, absolutely. Been working on healthcare for about 30 years. I am originally from Connecticut. Grew up, doing a lot of sports: football, wrestling, lacrosse, and came to DC for college and never left. And ended up working on Capitol Hill for about 12 years as professional staff, and was ultimately the staff director of the Ways and Means Health Subcommittee, where I worked on 9 different laws, mostly in the Medicare space. But really, one law in particular that grabbed my attention was the precursor to the High Tech Act. So getting data and technology integrated into healthcare to make healthcare work better for people, and have been on a 20-year journey ever since to continue that mission and hopefully end up achieving it. So in 2007, started Horizon Government Affairs. We're a bipartisan firm here in DC. We've got a team of a couple dozen experts, and we represent clients exclusively in the healthcare space, with a keen interest in using technology and data to make healthcare excellent for people.
Joel and I talk a lot, and share that with folks on the outside of our little world. And we have wrestling backgrounds in common. And we were joking around when we were talking about this discussion, which is it's a very interesting time in the federal government, to say the least. There's a lot of change. And one of the metaphors we made was, and lots of people are not familiar with wrestling. It's a small universe, but in wrestling matches, there's often a point where one opponent will throw another, and they both hit the ground. And often, who wins matches is the person who can react faster in that split second where everybody freezes.
Yeah, and believe me, I've been slammed to the mat and had to respond, and it's hard. And feel like there's a lot happening in DC, but and where people feel like they may be slammed to the mat. And there's a thing in wrestling called the reversal, and you can score a point if you kind of reverse on your opponent. And there's a lot of reversals going on from the discontinuity between previous policy and new policy, and so trying to manage all that. But I think the continuous thing throughout last couple of years, and certainly this year, is cost is king, right? Right now, we've got 93% of people who have some source of healthcare coverage. The other 7%, the vast majority of them are eligible for coverage but not signed up. Um, so you got to ask yourself, with so many people covered, why are people struggling with cost? And the answer is that medical costs are increasing premiums. Premiums are growing faster than income. So people are on this hamster wheel where they're losing ground from a take home pay perspective because they're paying so much for healthcare. And if the current trends persist, about 40% of the typical American's household income will go just on healthcare. And that means they're not spending it on education for their kids, or food, healthy foods for their family, or reliable transportation, or a solid home and roof over their heads. So it's crowding out a lot of stuff, and it's creating real problems at a micro level that's aggregated up to a macro level, where members of Congress and the administration are saying we got to do something on cost.
Yeah, and it's sort of, it's the figure that's shocking when you think about people spending 30 or 40% of their income on healthcare, when we have one of the most expensive healthcare systems in the world. We have some of the poorest outcomes in the Western world, certainly among the top producing revenue countries in the world. And it's been an ongoing thematic conversation that sort of never seems to go away. We have a litigious system that puts providers at risk. We have very, very expensive healthcare education. We have this huge payback period for people who come into the ecosystem. We continue to reduce reimbursement rates, and we don't have great primary care and preventative care. Right? It's sort of
Yeah.
this mass struggle of things that, quite frankly, if you were to attack, and I talked about this in a panel I was just on recently, was if you just ensured everybody got preventative care, effective preventative care, the impact to the overall system would be gigantic. But we have people who are, to your point, big copay. Well, maybe I'm not going to go get that preventative visit, or I'm not going to get that vaccine, or I'm not going to do X or Y. And then they end up in the ER by hook or by crook, not intentional, right? But they end up using the ER as primary care, which we know takes the cost up 10, 20, 100x and may
Right.
result in a hospital visit as opposed to a preventative care visit. It's an
Yeah.
interesting moment where we've got a lot of conflict, but also we've tried a lot of things over and over again that haven't really been successful. Um,
I think that's a really important point. We it's not that we don't know where the problems are, and it's not like we don't have multiple policy solutions to apply or market incentives or technology or data solutions to be able to go after that. Well, I mean, we see like across markets, Medicare, Medicaid, ACA, employer, individual, like all these discrete problems. And the one kind of unifier across all those markets, Don Berwick did the original work on this. He was in the Obama administration, uh, and then subsequent research since then shows about anywhere between 25 to 40% of the care that we receive as patients is waste. And to me, like eliminating some of that unnecessary care will lower costs, which will then lower premiums and deductibles, or should. And that would get patients better access. And then you highlighted a very critical point, particularly in Medicaid, where we see about 35, 36% of people who lack access, convenient access to a doctor or a specialist. So they're showing up in the emergency room for primary care or for a problem, and that could have been handled in a much less expensive setting. So it's like we know all this. Like,
yeah,
how do we solve it, right? And I think data and technology is a foundational solution to say, like, I can spot that problem, I can direct that person to a better resource, a lower cost resource, et cetera.
yeah. And I think the access to care problem is one of the critical ones, right? This is a place that's been a problem forever. I'm a nurse, I've been in the nursing field since '94, and I keep reiterating this point, but in all of the years I've been connected to the healthcare system as a working participant, forget as just a functional member of patients, there's never been a 2 or 3 year period where we didn't have a primary care physician shortage or a nursing shortage. Um, and as we've advanced the ability to actually deliver more virtual care, variability on place of service, transportation options have increased. We've never sort of found a way to crack the code, especially for Medicaid populations, to reduce the barriers to care in this space and make sure that people have access, whether it's the hours, making sure people have the health literacy to actually navigate a digital solution. Because even if I could put it in your hands, but you didn't understand the process, you wouldn't use it. There's a distrust from a lot of people about putting their data out in the digital ecosystem.
Yeah, we got to recognize that people are in different places, different starting points.
100%. And as you push digital, and this was the interesting thing during COVID, everybody learned to access their patient portal. And you know, I use my family as an example. We went through someone in my family got leukemia and had to have a bone marrow transplant. And there's a huge lack of medical literacy, in a family that has good health care and that, lives in New York, lives near a major city, is not distant from their healthcare providers, has had lots of historical encounters with the healthcare system, unfortunately. But when you get access to your full chart, most people don't know what they're looking at. They don't understand the tests they're seeing. They don't understand what a positive or negative result in the test might be. It might be irrelevant. It could be something really critical. And they don't really know how to talk to their provider about that information either. So to your point, even once you get access, you actually might not be able to leverage it, whether it's because of tech or understanding or the fact that you can't integrate the digital and the analog services in a way that actually people can digest. 'Cause it's one thing to hand you some information, make an appointment, have a telehealth visit, and then say, okay, well, now I need to see you. And it's like, well, you don't have any appointments outside of business hours, or you don't have any appointments that I can get to on public transportation. So it's the same pathway, and that's where we get into sort of the social determinants end of this. Is there are a lot of folks, even with the best healthcare, even with a full plan, even with low copay, can't consume the services for one reason or another.
Right.
Yeah. And
Which I think the big benefit for the discussion that we've had over the last several years, decades even, on social determinants of health really is a more holistic view of what's happening out there, right? And so I love technology. I want to hug the robots, right? Like I'm a
Mhm.
big believer in technology. But I hear some people who say, well, now we've got AI and that'll fix everything. And I think it's a puzzle piece. It's a part of the solution. We can't lose that whole view of what's actually happening on the ground with people as they try and like figure out the access problem, certainly, but the cost problem too is um it's a whole solution, right? Like it can't be just like, well, AI is gonna be the magic wand that'll fix everything, or we just need to break up the market and address consolidation.
And so as you think about that, most of what we're seeing that's actually effective is not in the diagnostics or full patient integration or replacing a physician or a provider with an agent. It's much more about how do I reduce the amount of administrative time we ask providers to engage in so they can scale up their delivery capability. Right. And I think that's a win. All right. So the reality is we can serve more people under it where we have essentially a gap in the scalar ability of for us to grow new providers and nurses where we have a hole. So how do I make it easier for those folks to manage those populations? But to your point, like there's a finite cap on the ability to optimize any human to a degree. There's still only so much work you can do in an 8-hour day. And so we're going to have to fill in the rest of that with things beyond just agent-based help for healthcare. It's got to be a bigger solution.
Yeah, I think that's true. I'll throw just two stats out at you on to this point. Like uh, back when we were in the early days of federal support for electronic health record adoption incentives through Medicare and Medicaid, um, there were numbers coming out. Even 4 or 5 years after those incentives started flowing, we have great adoption now, right? Like with hospitals and pretty good adoption with docs, about 75% of docs. But they're spending 40% of their time scribing and doing other stuff in the EHR. And I think the impact on patients was my doctor doesn't look at me anymore. He doesn't pay
Yes.
attention. He's on his keyboard. That's issue one. And issue two, I think it's right for quality. And we said, okay, if you do that, we will pay you a full inflation update in Medicare for reporting those quality measures. And the thinking was if you report on quality, we'll start to get quality data. And then we can start paying people off of performance or attainment on outcomes. And actually, it's starting to it's this movement towards value based care started with the quality reporting. And I think now what we see is that that well intentioned experiment in Medicare has morphed into a $1.3 billion collection burden on doctors, and the measures that get collected, the actual data that's collected in that program isn't used to compare across doctors because everyone's reporting something different. And it's kind of used a little bit to incentivize better outcomes, but it's a lot of process stuff, which is important. But it's still just like we built in a big cost structure into the physician and hospital worlds. We're not getting like a lot of juice for the squeeze. So like people in DC now are trying to figure out how do we change that so that doctor, nurse, pharmacist isn't sitting there doing a bunch of stuff that at the end of the day doesn't mean a hell of a lot for the patient.
And I think to your point, that's the great promise in AI, right? Which is
Yes.
ambient listening, automated, chart review. The fact that we've moved to a standard, which is actually a standard, we finally got in a fire. When we used to have CCD and CCDA, which was the standard bliss standard. It's terrible. As someone who had to integrate a lot of healthcare data, that's why I don't have any hair anymore. Right. But the reality is now that we're standards based, now that all the EMRs speak the same language, now that we have some agentic capability, the opportunity to reduce the amount of time that providers actually spend collecting not only case data, but all of the quality data. And then even there's a whole other system of healthcare that most people are unaware of. I happen to work in the space previously, is there's a huge set of quality improvement registries that actually exist from all of the quality improvement agencies. So like the American College of Surgeons and the American Heart Association collect case information in order to support like rare case analysis, quality improvement, standards of care development. That's all stuff that's done on a nonprofit dollar all across the country. And it's how all the health systems actually figure out how to treat patients they don't see that often, or improve their standard of care, or do large scale research dollars for essentially large scale research studies for very few dollars. That system also creates a burden because people have to do case review to get that data into the ecosystem. And in the last go around of builds I was engaged in, we were really trying to figure out how to derive that data from Fire. But also, here's the opportunity to start taking that from an AI agent perspective, push that into forms that were ordinarily entered by humans, and reduce all of the burden in order to raise the level of case collection. So you could actually use that same process to start to feed the quality measures because it's already standardized, it's already built on a national standard. And there is opportunity there, to your point. I think the other thing we saw as a result of all this collection was the length of a visit is now down in the single minute reviews. You're seeing doctor visits that are less than 10 minutes. And in a lot of cases, they're 3 to 5. And things get missed. Patients certainly don't feel connected or trustworthy, but also may not actually get the response they need. And we're obviously overloading physicians, which is where all the burnout comes from.
There's actually something in the law that says if you've got a clinical quality data registry, that should be sufficient for meeting Medicare's quality reporting requirements. But it's been a war and a battle with the Medicare agency, CMS, to kind of get them to recognize that these homegrown, very valuable data registries are in fact much more valuable than trying to report on the 492 measures now, I think, in the Medicare list that were developed by other people that may or may not be relevant to the specialty, that may or may not ever be used to do anything other than just report into Medicare.
Well, and I think the reality is you can do both, right? Which is you could augment the collection for a specialty registry with a baseline collection that's automated out of Fire, for argument's sake, and say,
Yep.
look, how much of this can we derive, and EMRs from a coverage perspective would reduce a fantastic amount of burden in the healthcare system, right? It's really just a easy entry point. There's an option here, right, where you start to apply sort of, I don't want to call it easy button, but really, an augmentation process for providers where you can source the record next to the EMR record, ask somebody to validate it as opposed to enter it. And now you've cut what was a 8, 10, 15, 30-minute process down to 2. And now you're going to get compliance, right? And to your point, then I'm not filling out 400, maybe I'm only filling out 40.
Yeah.
And those cut down on the burden dramatically, but give us real data to look at across the system.
But even if you're just reporting on 5 and 2 of them are a 30-minute process, I mean, like, I think
Yes.
one of the conversations in DC is, should we have a filter on the quality measures that says if this can't be done automatically as a result of a reconciliation process between EHR and other data
Mhm.
sources, then we don't want to end the program.
Yeah, the burden
Because
level
we have
matters.
so
Yeah.
there's a value judgment being made right now in Washington around, like, we thought quality reporting regardless was valuable. Maybe we ought to balance out quality reporting with burden
No.
and then make a value judgment